All right, so welcome to part 2 of the pharmacology series. And in this particular lecture, we're going to cover bronchodilators. So we're going to center on pulmonary drugs. And the bronchodilators that we're going to be talking about this evening are going to be the beta agonists, the anticholinergics, as well as the xanthines. And if time permits, we're also going to talk about leukotriene modifiers, as well as corticosteroids. So yesterday, we talked about the cardiovascular drugs or drugs that affects the heart. And now we're going to, of course, talk about drugs that affects the lungs. Okay. All right. So we're now going to begin with respiratory pharmacology, as I said. These are drugs used for the management of common respiratory disorders. This is going to be a second part of the pharmacology series. All right, when we talk about respiratory drugs, they come in many forms and preparations, actually. However, most are given by inhalation, although it could be given by mouth, transdermal, or topical routes. Now, giving medications by the inhaled route has several advantages. And that is why most of these medications that we will be talking about today are inhaled medications. The reason they have several advantages over systemic administration is that, number one, a smaller dose can be used, as well as adverse effects are often reduced, and the drug is delivered quickly to the lung tissue or the bloodstream. And of course, it is painless because you don't have to inject it, and delivery is usually safe and convenient. So let's now focus on bronchodilators. What are bronchodilators? Well, a bronchodilator is a drug that relaxes the bronchial muscle. And when this happens, therefore, it results in the expansion of the bronchial air passages. So these medications, bronchodilators, are indicated for individuals that have lower than ideal airflow. And the mainstay treatment of beta treatment is beta-2 agonists. And these beta agonists target the smooth muscles in the bronchioles of the lung. So if you remember yesterday, I said that there were 2 receptors for beta, and beta-1 receptors were those that were specific to the heart, and beta-2 receptors were those that were abundant in the lungs. And beta-2 receptors are actually going to cause bronchodilation. So there are various respiratory conditions that may require bronchodilators, but the most common one is going to be asthma as well as COPD. Now, they're either used to reverse asthmatic symptoms or improve the lung function in patients with chronic obstructive pulmonary disease. So basically, there are 3 types actually of bronchodilators, and you could remember them by looking at BAX, B-A-X. So it stands for beta agonists, the A stands for anticholinergics, and X is for xanthines. So these are the 3 types of bronchodilators that are used. So remember BAX, beta agonist, A for anticholinergics, and X at xanthines. So let's take a look at each one of them. We begin with the first class of bronchodilators, which are the beta adrenergic bronchodilators. Now, what is their action? Again, yesterday we talked about that entry of norepinephrine into beta-2 receptors are going to dilate the bronchial muscles. And that's exactly how this drug works. And they dilate the airways by relaxing the muscles that surround the airways. So again, if you recall our discussion of the adrenergic receptors yesterday, there are alpha and beta receptors for adrenaline. alpha receptors, just to review again, are abundant in the blood vessels, and entry of adrenaline here will cause vasoconstriction. Beta receptors, on the other hand, are other kinds of receptors to adrenaline. There are two kinds of beta receptors, again, beta 1 and beta 2. So I'm just repeating the information so that it becomes second nature to you. I'm just going to write something, so I'm preparing my pen. So beta receptors are of two kinds. There are beta 1 and beta 2. And as I said yesterday, you can remember which one is beta 1 because we have one heart and we have two lungs. So when we have beta 1 receptors, these are abundant in the heart and beta 2 are abundant in the lungs. And what we're interested in today is going to be the action of these particular drugs onto the beta 2 receptors. So whenever we give beta 2 agonists, an agonist is a drug that increases the effect of something. So we're increasing the effect of beta 2 receptors. So this is going to cause relaxation of the muscles of breathing. And thus they open the airways. Okay, so that's exactly what we're going to be talking about later on in more detail. But these medications actually are going to end with a suffix sterol. So remember, these drugs are used for acute asthma attack and are usually given before any other drug. So if a patient is getting beta agonists as well as steroids, we give the beta agonists first. Now, out of the three classes of bronchodilators, these produce the greatest bronchodilation, particularly in patients with asthma. So they're both preferred for the relief of acute symptoms and for the prevention of exercise-induced bronchospasm. Okay, so when we talk about beta agonists, there are two forms or categories of this medication. They are either short-acting or long-acting. And short-acting beta agonists are known as SABAs, and it stands for short-acting beta agonists. These are used as a rescue medication, and therefore it is a PRN medication. It is used on an as-needed basis to control the symptoms of asthma. The other form of beta agonist is going to be LABA. And LABA are medications that are long-acting beta agonists. These are usually scheduled medications, so they are used regularly, as much as twice daily, particularly in patients who have poorly controlled asthma. And they're usually also going to be in addition to the use of corticosteroids. Okay, so what are some of the examples of your beta agonists? Well, salbutamol, salmeterol, formoterol, and so on are going to be examples of these medications. All right, the other bronchodilators are the anticholinergic bronchodilators. So you remember the acronym BAX. So beta agonist was the first one. And then the second one is anticholinergic bronchodilators. So what does anticholinergic bronchodilators do? Well, they block the effect of acetylcholine. So you remember yesterday we talked about the cholinergic system. And whenever acetylcholine is released, it's going to cause constriction of the airways and the nasal passages. So again, this is mediated by a substance called ACH or acetylcholine. And what they do whenever they're activated, as we said, is that they're going to cause narrowing of the airways by stimulating the muscles of the airways to contract. So whenever you give anticholinergics, therefore, you do have the opposite effect. You will have relaxation of the bronchial muscles, and therefore the muscles are going to be widened or dilate, and thus it's going to make breathing a lot easier. All right, the way in which we identify anticholinergic medications is they always end in tropium. An example of that would be ipratropium, tiotropium. So we're going to discuss this more in detail, but this is just differentiating the three different kinds of bronchodilators. And of course, the last bronchodilator is the X, and it stands for xanthine derivatives. Theophylline is one xanthine derivative that is well known. Now, what is the action of xanthine derivatives? Well, xanthine derivatives act by opening the airways, by relaxing the smooth muscles in the walls of the airways. So it is not fully understood how it does that. But maybe they think that the reason why this occurs is because it blocks the action of a substance called PDE, or phosphodiesterase. And what is this phosphodiesterase? Also known as PDE. And what it does is that it actually blocks the production of CMP, and CMP causes a dilation of the bronchi. So whenever you have xanthine derivatives, therefore, they may dilate the bronchi by blocking this action so that you will have more of this CMP. So the major effects, again, are going to be smooth relaxation of the muscles and dilation of the bronchioles. And these medications usually end in fill-in. So examples are aminophylline. The other ones are not that known. They are called difixilin. And the other one is oxtriptyline. So these are not as popular as aminophylline, of course. Okay, so those are the three bronchodilators. So I want to focus now on the first type of bronchodilators, the beta agonists. So let's take a closer look at how these medications work. So as I said, beta agonists are drugs that are commonly used during the acute phase of asthma attack. And this, therefore, the reason why we use it for an acute asthmatic attack is it quickly reduces airway constriction, and therefore restore airflow. So beta agonists imitate the effects of epinephrine, which we talked about yesterday, on beta receptors. So beta receptors, again, yesterday we talked about two types of beta receptors, beta 1 and beta 2. So in order to avoid the cardiac effects of beta 1, we only want to have the effects of beta 2. So we are always going to use beta-2 selective agents in order to have a lesser complication or side effects in the heart. So we want to create bronchodilation without having to cause tachycardia, for example, right? So the most common medication that is going to be a beta-2 adrenergic agonist and is albuterol. So albuterol means to say that this is a fast-acting agent. So, you probably have heard of albuterol as Proventil. That's the most popular trade name of albuterol. This is a short-acting beta agonist, so it's fast-acting, short-acting. And the other one is salmeterol. Salmeterol or Aerol, salmeterol, is going to be long-acting. And you probably have heard of salmeterol as Cerivent. That's the brand name for it. Okay, so one is short-acting, the albuterol, and the salmeterol is going to be long-acting. And there's always going to be confusion as far as salbutamol versus salmeterol. Okay, so don't get into caught into the trap, because the albuterol is also known as salbutamol. Okay, so this is also called albuterol. But nonetheless, if the question asks you which one is short-acting and which one is long-acting, if you take a look at this, sal B is the third, the next letter, and over here is sal M. Okay, which one comes before or earlier in the alphabet? B comes earlier in the alphabet, so therefore this is the fast-acting form. Okay, and salmeterol is going to be the long-acting form. So this is a SABA, salbutamol, and salmeterol is a LABA, a long-acting beta agonist. Okay, so always remember that. Don't be confused, because salbutamol is oftentimes referred to as albuterol. That's the other name. And the long-acting one is salmeterol. So to distinguish between the two, think about salbu B is going to be occurring first before M, and therefore that's the fast-acting medication. Okay. All right, let's go to the first poll. Okay, so let's take a look at the correct answers over here. So aerosols are often the drugs of choice to treat asthma because of what characteristics? All right, so aerosol products are ideal for the treatment of respiratory distress because they act directly on the airways. So obviously this is going to be correct. And because of the fact that it goes directly into the respiratory system, you could actually give smaller doses, and therefore they produce fewer adverse effects than oral or parenteral drugs. Aerosol products also produce a relief of asthma symptoms in a quick fashion. So letter E is also correct. So A, B, C, and E are the correct responses. So again, I told you before that the scoring of NCLEX has changed so that when it's select all that apply, it's right minus wrong. So if you're not sure about a choice, make sure that you don't choose that, okay? Just go ahead and forego that because the scoring is going to be right minus wrong. Okay, let's go to another one. Okay, so the correct answer here is albuterol or salbutamol. That's the other name for it. And so remember again that the salmeterol is M, so this is a LABA. It's a long-acting beta agonist. And of course, fluticasone, because it ends with azone. Anytime you see azone, like hydrocortisone, for example, this indicates that this is a steroid. Okay, it's a corticosteroid. And then, of course, tropium, you remember, are going to be your anticholinergics. Okay? All right. Okay, pictured over here are the sequence of respiratory medications during an acute attack. What you want to remember is the acronym AIM. So which one is the first one that you need to give? Well, you need to give the short-acting beta agonist first, followed by anticholinergics, then steroids. So A stands for albuterol, I for ipratropium, which is going to be an anticholinergic, and then, of course, your methylprednisolone, which is going to be your corticosteroids. So in addition to azone as a suffix of steroids, olone is also another suffix for steroids. Okay? All right, so I think we already talked about these, the mode of action of beta-2 agonists. So their indications is to prevent or relieve bronchospasm associated with asthma, bronchitis, or others. And so I just wanted to talk a little bit about these others. Now, one of the main uses of beta-2 adrenergic agonists would be in obstetrics. It is a tocolytic agent. And what this means is that it's going to delay contractions. And the other use is to manage patients with hyperkalemia. The reason is beta agonists will drive potassium into the cell and therefore will relieve hyperkalemia temporarily. Okay, so that is how it acts or how the indications are as far as beta agonists are concerned. Now, beta agonist is either a SABA, a short-acting beta agonist or a long-acting beta agonist. And as you could see, the reason why it's short-acting and they're the most effective drugs for the treatment of acute bronchospasm and asthma is because they act quickly and they could last up to 3 to 4 hours. So these are the first-line medications for the acute treatment of asthma symptoms as well as in exacerbations. Now, LABAs, long-acting beta agonists, are also used in the treatment of patients with asthma and COPD. And they're usually given in conjunction with corticosteroids. Well, they have an onset of action that is more than 5 minutes, but it lasts longer. The duration of effect is at least 12 hours. So as you could see on the beta agonists, they act quickly, but they also disappear quickly. Long-acting beta agonists will have a quick action, but the duration of its effect is longer. So that is 12 hours. Nowadays, there's also what is known as an ultra-LABA, and they're not used much because this is new. This is usually going to be a once-a-day treatment, and the drug that is going to be that is Indicaterol, this one right here. It's a ultra long-acting beta agonist. Okay. All right. So the most common SABA that we use today are your Ventolin, your Acuneb, your ProAir HVA, which are the trade names for Albuterol. And then, of course, the other SABAs that could be used are your metoprolterenol, your levalbuterol or Sopinex, and Perbuterol or Max Air. So these are going to be administered in different ways. And if you see over here, it says HFA. Well, HFA stands for a transporter, a chemical that is used to send the medication into the lungs. And that stands for hydrofluoroalkane. So just as an information, if you're trying to find out what that HFA stands for. Okay, let's go to another poll. Okay, I think that you got that correctly. So whenever we are giving these drugs, because they're adrenergic, they mimic the effect of epinephrine, then we have to be mindful that its use could increase blood pressure, and therefore it would be contraindicated or should be used cautiously in patients with hypertension. Now, the other thing is that obviously it's going to create also, remember that epinephrine is a neurotransmitter as well, and therefore it could precipitate or worsen seizure disorders. Diabetes mellitus, because you remember whenever you increase your epinephrine, it stimulates the production of glucose. So it's a glucocorticoid, and therefore it would be used cautiously in patients with diabetes. Hypothyroidism, well, it should be used consciously in patients with hyperthyroidism, not hypothyroidism, because in hyperthyroidism, there's going to be an increase in metabolic rate, and therefore giving adrenergics will make it worse, and not also going to be associated with renal failure. So the most likely answers to these would be A, B, and C. All right, so let's go back to LABAs. And when we talk about LABAs, or long-acting beta agonists, these medications are never used alone. They're used in conjunction with inhaled steroids. So the reason why they're not used alone is because they have found out that there are a lot of complications, also sudden death, associated with the use of LABAs alone. So therefore, LABAs are not given as routinely as SABAs. And when they're given, they're actually used in conjunction with steroids. So these are usually given twice a day. So it could be given as a dry powder inhaler, like in Cerevent. And of course, the other common LABAs are your Formoterol, as well as this one, Salmeterol, and Advair and Dulera. Okay, so these are the LABAs. We're not going to talk about the ultra-LABAs. These are the ones that are given once a day, and they have, of course, longer-acting medications. Now, let's talk about the adverse effects. So the adverse effects of beta-2 adrenergic agonists are going to include cardiac events. Now, you're going to say, I thought that we are only going to selectively affect the beta-2 receptors, but there's still some effect on the heart. The majority of its effect will be on beta-2. So if it affects the heart, it will be manifested as tachycardia as well as arrhythmias. And because of the fast heart rate, it might precipitate ischemia. So patients might develop chest pain as a result of the use of beta-2 adrenergic agonists. As far as metabolic effects are concerned, notice that it is going to decrease potassium. And that's why one of the uses of beta-2 agonist drugs is to decrease potassium, or to treat hyperkalemia. And then, of course, because it's a glucocorticoid, it's going to increase blood glucose. And sometimes it causes tremors. So patients feel like they might feel like they had drunk a lot of coffee. So that's how they describe this side effect. And this is going to be one of the side effects that might be bothersome to some patients. Okay, so this is a frequent question in NCLEX. So in this particular instance, the patient is supposed to get 2 puffs of albuterol every 6 hours. So what is the spacing of these 2 puffs? And this is important. Well, the correct answer here is 3 to 5 minutes. So whenever you are giving the same medication, the patient should have to wait 3 to 5 minutes between each puff of the inhaled medication, if they're the same, okay? If they're different, it's something else. And we'll talk more about that later on. All right, there are some nursing responsibilities, particularly education, that we're going to have to emphasize to patients on beta agonists. Now, during an asthmatic attack, we instruct them to take 2 to 4 puffs every 20 minutes for 3 rounds. If it does not work, then they have to notify the healthcare provider or go to the emergency room. It is also important to incorporate the medications well. And so we have to instruct them to shake the canister before using it. And then, of course, the way in which to use it is that they must breathe out first, and then they push the inhaler and inhale, and then hold their inhalation, and then exhale after a while. So that's important, that the timing of the inhaler being pushed to the inhalation must be done simultaneously. And the objective here is actually to deliver the medication during the last third of inspiration. So if this is the inspiration phase, what we want to do is to deliver the medication right over here, so that it will be delivered to the major bronchioles so that bronchodilation can occur. And then, of course, make sure that we instruct them to clean the inhaler once a week. Now, how do we know that they're getting better? Well, a decrease in respiratory rate is going to be one of them. And of course, an improvement in the oxygen saturation. Now, whenever you're giving bronchodilators, it is obvious that the patient is going to start coughing productively. And therefore, this is going to be an expected result of giving the bronchodilator. And then, of course, because they're going to be breathing much better, there's going to be a decrease in anxiety. And then, of course, there's going to be also, because of the effect of the beta agonist, there will be bilateral hand tremors. So these are expected findings. Okay, so you remember in the case study method, one of the questions to evaluate your ability to see if there is going to be an improvement of the patient or a deterioration of the patient. And that's why it is included here. Okay. All right, so we talked already about albuterol, which is also Proventil and Ventolin. I just wanted to show you some of those. And then, of course, your salmeterol, which is your LABA. And the other ones are going to be these medications. Okay. So for SABA, you have flat, your phenoterol, levalbuterol, albuterol, and terbutaline. So those are the medications that are SABA. And of course, your LABA will be your formoterol as well as your salmeterol. So that's the way to remember what the SABAs are, is flat. F for phenoterol, L for levalbuterol, A for albuterol, and T for terbutaline. Always remember that albuterol is the same as salbutamol, okay? All right, this was similar to the question that we had earlier. And so let's take a look at what the correct choices are going to be. All right, so sympathomimetic, it's a little bit, it's worded differently. But again, hypothyroidism is not going to be a contraindication. While we should always assess whenever we are administering a sympathomimetic that they're not allergic to it, number one, and that they don't have cardiac disease. So cardiac disease is going to be included over here, as well as vascular disease, because it causes vasoconstriction, if you remember. Arrhythmias would be another one, as well as diabetes, because again, epinephrine is a glucocorticoid, and of course, arrhythmias. So the correct answers are B, D, and E. All right, so that ends the discussion on beta-2 agonists. Let's now go to the A. You remember it's BAX for bronchodilators, beta-2 agonists, anticholinergics, and xanthines. So let's talk about anticholinergics. The other name for the cholinergic system is the muscarinic system. And so whenever we are saying anticholinergics, they're also known as antimuscarinics. And these medications are mainly used to treat COPD, but they could also be used actually for asthma. So when we say again cholinergic, we are talking about the parasympathetic nervous system. Because if you remember from yesterday's discussion, we did not talk a lot about the parasympathetic nervous system, but the autonomic nervous system has two branches, the sympathetic, which we talked about yesterday, and the parasympathetic. This one is the one that secretes norepinephrine, and that's why it's called the adrenergic system, from the word adrenaline. The parasympathetic nervous system exerts its effect through another substance, and that's acetylcholine. And therefore, this is also referred to as the cholinergic system. Okay. So there are two kinds of receptors in the parasympathetic nervous system. And the first one is what is called nicotinic, and the other one is muscarinic. So these are the receptors that we're interested in because they're abundant in the lungs, and therefore this is going to be the one that we're interested in. So when we give muscarinic agents or anticholinergic medications, we are going to always remember that this is a parasympathetic effect. So anticholinergic medications could be identified by the suffix tropium. So whenever you see a drug with the suffix tropium, that means to say that it is an anticholinergic medication. All right, because we did not talk about the parasympathetic nervous system yesterday, we're now going to look at what are the effects of acetylcholine when it goes into your receptors. So it causes pupillary constriction, stimulation of saliva, it constricts the bronchi, and that's exactly why we are interested in it, slow heart rate, stimulate the production of bile, stimulate digestion, stimulate and causes an erection. So the reason why this is important is if you give a medication that is anticholinergic, what then are the anticipated side effects? Okay, so the side effects would be pupillary dilation. dryness of the mouth and mucous membranes, bronchodilation, and you will have tachycardia, a decrease in bile production, and constipation could also occur, and erectile dysfunction. So when you are being asked about cholinergic effects, these are what they are talking about, the side effects to giving anticholinergic medications. So whenever you're giving anticholinergic medications, always think about what it does to the pupils. It dilates it. That's why when you give atropine, for example, which is an anticholinergic, or atropine-like drugs, they're going to cause pupillary dilation. And the reason we give it preoperatively is because it dries out the secretions and therefore decreases the incidence of aspiration during surgery. And then, of course, tachycardia and constipation, as well as erectile dysfunction. So all those are the effects of the parasympathetic nervous system. So as I said, there are two types of receptors for your acetylcholine, and they are your muscarinic receptors and your nicotinic receptors. So let's take a look at the muscarinic receptors. They function in the central and peripheral nervous system. And are present in various organs throughout the body. So the nicotinic receptors, on the other hand, function in the central nervous system and neuromuscular junction. So this is exactly what exerts its effect in the lungs. And that's why we're going to use it in the management of patients with COPD, as well as in asthma. Okay, so what are the effects, again, whenever you have muscarinic receptors? Well, bradycardia, bronchoconstriction, increase in GI motility. Again, we had talked about that. So if you block these, you're going to, you're going to have the opposite effect. So it's the same thing that I have talked about in the previous slides. So similar to beta agonists, beta-2 agonists, there are three types of anticholinergic bronchodilators. Again, they could be short-acting anticholinergics or muscarinics. And the other one are long-acting, again, and ultra-long-acting. So the ones that are most commonly used are these ones, ipratropium or Atrovent, and sometimes combinations of Atrovent and Albuterol, and that is known as Combivent. Okay, so these are the most typical drugs that we use in the management of patients with COPD, the short-acting ones. However, they could also use the long-acting ones as maintenance medications because these are going to be rescue medications. These are going to be regular maintenance medications. Okay? So the only thing I wanted you to remember about anticholinergics are the cholinergic effects. Those are the most important ones. Okay? So these medications are good for the relief of bronchospasms as well as shortness of breath. The thing that is advantageous about this is you can combine your short-acting beta agonists as well as your short-acting muscarinic antagonists, so or anticholinergics. And in addition to that, because of the fact that There are muscarinic receptors. They're minimal as far as cardiac effects is concerned. So it's an ideal drug for those who might have contraindications because of the fact that they might have tachycardia. And this is also good for patients who wake up wheezing at night because of its long duration. And it comes in a preparation as a dry powder, such as Spiriva. And the advantage of that is it does not require patient coordination or the use of a spacer in order for the patient to have the maximum dose. Okay, so it's a lot easier for elderly individuals. All right, so what are the precautions as far as teaching the patients? Well, you should always advise your patients who are taking ipratropium, for example, to increase their fluid intake. Because you remember the dryness of the mouth, it causes dryness of the mouth. And the other intervention for that would be to advise the patient to suck on sugar-free candy in order to relieve the dry mouth symptoms. The other one is that this should also be used cautiously in two conditions, in particular, in men, BPH, benign prostatic hypertrophy. Because what's going to happen if you give these medications to these patients is that they're going to have difficulty in urination. So it increases the symptoms of BPH, because BPH is an obstruction of the urinary flow. And the other one is that it has to be contraindicated in narrow angle glaucoma, because you remember it causes pupillary dilation. So if you dilate the pupils, you're going to cause more angle closure and therefore increase intraocular pressure. Okay, so these are the two conditions that are often going to be asked as far as contraindications for any anticholinergic. Okay, so anything that has, for example, atropine would be the same thing. You don't want to give if the patient has narrow angle glaucoma as well as BPH. Okay, let's go to another poll. Okay, the reason I started with this question before we talk about xanthine derivatives like theophylline is because of the fact that this is a very frequent question that comes out in NCLEX. The reason, the correct answer here is letter C. Okay, so let me just explain why it's letter C. Okay, nicotine increases the breakdown of xanthines in the liver. So if nicotine increases the metabolism of xanthines, then the xanthine dose must be increased in patients who continue to smoke while using xanthines. Unfortunately, this is a fact. A lot of our COPD patients still smoke, despite the fact that they cannot breathe in between. So remember this, that nicotine requires that the dose has to be increased in patients who continue to smoke, because nicotine increases the breakdown of xanthines in the liver. Okay, so this is a good segue to our discussion of xanthines, therefore. So the last of the bronchodilators are the X. You remember BAX. B was beta agonist. A was for anticholinergics, and the X is for xanthine derivatives. So what are some xanthine derivatives? These are medications that are very effective to treat bronchospasm, in particular, bronchospasm caused by asthma. So these drugs were once actually the main treatment choice for asthma and bronchospasm. I remember when I was going to school, that whenever somebody had an asthmatic attack or a bronchospasm, it always is going to be treated with theophylline or aminophylline. Now, because they have a very narrow margin of safety and they interact with many other drugs, they're no longer considered the first choice bronchodilators. So we try to avoid using this as much as possible now. So the key medication that falls within this class that you want to make sure you know is going to be theophylline or aminophylline. And so it gives you the clue that the suffix to this drug class is going to be a suffix ending in phylline. So when you see or hear a drug with the suffix phylline, this means to say that it is a xanthine derivative. So how does it work? Well, you remember me talking about CAMP or CAMP, okay, right here. Xanthine derivatives increase the levels of adenosine monophosphate or CAMP, cyclic adenosine monophosphate. That's what CAMP stands for. And it does so by inhibiting the activity of PDE or phosphodiesterase. So what happens when you stop phosphodiesterase, there's going to be an increase in CAMP. So what does CAMP do? Well, CAMP is a very effective bronchodilator because it relaxes smooth muscles. And so this obviously will cause bronchodilation, and therefore it's going to relieve the symptoms associated with asthma. Okay, so in summary, the action of xanthine derivatives relaxes the bronchial muscle, causing bronchodilation, which therefore makes the respirations of the patient much better. All right. So it mainly is used for the prevention or relief of bronchial asthma or bronchospasm. Now, it could also be used in unlabeled uses, like in patients with apnea, for example. And for those of you who had rotations in neonatal ICU, whenever patients or these babies have apnea and bradycardia, they usually treat them with xanthine derivatives. So it's a respiratory stimulant in this particular instance. Okay, this is a combination question from what we learned yesterday and today. So let's see. Okay, so let's take a look at letter A. Naproxen is a non-steroidal anti-inflammatory drug. And usually these types of medications are going to be most likely precipitate asthmatic attacks. So therefore, this is a correct response. So this is an NSAID. How about ipratropium for patient with glaucoma? Tropium is you remember, an anticholinergic, and therefore it would be contraindicated in patients with glaucoma as well as BPH. So this would be something that you would question. And of course, losartan for a patient with diabetes. Sartan is an ARB, angiotensin receptor blocker, which we talked about yesterday. And we talk about its protective action on the kidneys. And that's why we give it to patients who have renal failure. So this would not be questioned, right? How about theophylline? So this is going to be your xanthine derivative for a patient taking cimetidine. Well, you probably don't know, but now you know that there is going to be a contraindication because there's going to be a reaction whenever theophylline and cimetidine are taken together. So this would be something that you would question. And of course, atenolol for a patient with asthma. Olol is a beta blocker, but we need to find out what kind of beta blocker is this, okay? Do you remember which ones were cardioselective and the ones that are non-cardioselective? Okay. So we said last night that any medication, which is a beta blocker, that begins with an A all the way to N is most likely to be just cardioselective. So it only works on beta-1 receptors. Okay. So non-cardioselective are those that work on beta-1 and beta-2, and they're usually the ones that starts with the letter O to Z. And of course, there's going to be a what do you call that? A exception. There are two notable exceptions to this rule, and they are carvedilol and labetalol, because carvedilol, sorry about that, carvedilol and labetalol are going to be non-selective. Despite the fact that there are C and L, they're still going to be non-cardioselective. Okay? All right, so what are the major side effects or adverse effects of the use of xanthine derivatives? Now, I failed to tell you that xanthines are actually related to caffeine, caffeine as well as cocoa. And therefore, you can remember a lot of patient teaching and side effects by thinking that it's going to have the same effect as drinking a lot of coffee, okay? So what would you experience if you drink a lot of coffee? Well, tremors, for example, anxiety, tachycardia. So this is going to be some of the classic signs and symptoms of the side effects that are associated with xanthine derivatives. So I wanted to just write over here, think of coffee, because these xanthines are relatives to coffee and cacao. Cocoa. Okay, so the other thing that we do not want to forget in these drug is the 3 T's. And what are those 3 T's? They're toxic anytime they're 20 mics per milliliter. So we always have to get blood levels whenever you were giving aminophylline. And obviously, if the blood level is 20 micrograms per milliliter, that means to say that the patient is toxic. And it could cause tonic-clonic seizures whenever there is toxicity. And then, of course, tachycardia as well as dysrhythmias are going to be very common. The other thing that needs to be emphasized, I already talked about avoiding coffee. And then, of course, the nicotine effects. Remember that it increases the metabolism of xanthines. And therefore need a higher dose. Now, because it could increase heart rate, obviously before cardiac stress test, this should be stopped. Now, the drugs that increases the toxicity, you remember one of the questions that we had is cimetidine as well as ciprofloxacin or Cipro. These drugs should be avoided because they increase the toxicity. And of course, concurrent beta blocker use blocks the effects of theophylline. So we all know that if we give beta blockers, we're counteracting the effects of theophylline. So those are the important precautions as far as xanthine derivatives are concerned. And some people have proposed that the way that you remember this is to think about THEOP. So T for tremors, H for heart irregularities, E for electrolyte abnormality, disorientation for O, and pain in the abdomen, as well as headache, restlessness, and seizures. So I don't know if this is going to help you, but sometimes it does help to remember what we are looking for as far as xanthine derivatives. Okay, so we have passed the 1 hour mark, and what I'd like to do is to have a 5-minute break, and then we'll come back to talk more about the other drugs that are going to be acting on the respiratory system. Okay, 5 minutes. Okay, 5 minutes is over, so let's go ahead and get started again. So in this particular slide, I'm just trying to emphasize the patient teaching things that you have to include in patients relative to the use of your bronchodilators. So for beta agonists, make sure that you remember that long-acting beta agonists or LABAs are not going to be for acute treatment. They're intended to be for long-term maintenance therapy. Avoid precipitating events, meaning to say that in asthmatic patients, they should be able to identify what triggers their asthmatic attack. And of course, we need to include proper instructions on how to use a metered dose inhaler or an MDI, as well as dry powder inhalers. For anticholinergics, avoid ipratropium for all allergies to soybeans, peanuts, or other legumes because they are relatives. So that's one thing that I didn't mention earlier. And because of its drying effect, we need to encourage fluids on these patients. And remember that they're contraindicated for glaucoma as well as BPH. For your xanthines, the important thing is that smoking decreases the blood concentrations of aminophylline or theophylline, and therefore you would require an increase in dose if the patient continues to smoke. And the other thing that I didn't mention is charbroiled foods decreases the blood concentration of xanthines. So we don't want them to be having a lot of food that has been prepared in a charbroiled or grilled. And of course, because of the side effects, we want to avoid caffeine or foods that contain caffeine or cocoa. Okay. All right, let's go to another question over here. Okay, so let's take a look at the correct answers. Remember that when you're thinking about theophylline toxicity, always think about drinking too much coffee. So if you drank a lot of coffee, you're going to have a feeling of nausea as well as vomiting. So letter A is a correct response. Letter B is incorrect because it should cause insomnia. And this is saying that the patient was sleeping very soundly. I feel like my heart is beating faster than usual. Well, tachycardia is going to be another side effect. Headache is also going to be a side effect, and vomiting is also a side effect. So a report of being restful in sleep would not suggest that the patient ingested a lot of coffee or is experiencing theophylline toxicity. Okay, and the last drug that we're going to talk about today, I'm going to move forward, is going to be your inhaled corticosteroids. And the reason I moved over here is because of the fact that your beta agonists as well as your anticholinergic medications are going to be used in conjunction with inhaled steroids. So steroids are easily identifiable because they have the suffix azone or onide. So these are the most common suffix for corticosteroids. An example of that would be your fluticasone, for example, or cyclosonide. Those are indications that they are steroids simply because they end with azone or onide. So why are steroids used in the management of patients with bronchial problems such as asthma and COPD? Well, they are usually given by inhalation, and they have an advantage over those that are given orally in that their action is relatively limited to the lungs. So this generally limits, although it does not totally prevent it, the systemic effects that we would get when we take steroids by mouth. So what is the major effect of steroids that we're going to be interested in? Well, we're going to be interested in its anti-inflammatory effect. So the inhaled corticosteroids that are common here in the United States are Flovent, that's one of the most common one, which is fluticasone, or Pulmicort, which is budesonide. So these two are the most common ones that are going to be used here in the United States. And they come in three different forms. They can be delivered by HFA or MDI or metered dose inhalation, as well as DPI and nebulization. So these are going to be the ways in which these drugs are going to be delivered. Now, what are the side effects of steroids? Well, this is the major concern when we're dealing with inhaled steroids. They don't cause the same complications or side effects as when patients are on oral steroids. So they have fewer side effects, especially at lower doses. But the most common are oral candidiasis, and also hoarseness and changes in the voice and cough. So what is going to be the solution, therefore, if these are the most common side effects of the use of inhaled steroids? Well, they can be minimized with the use of a spacer, particularly when you are using a metered dose inhaler. Also brushing the teeth, right? And gargling after use. And this is to help reduce residual medication in the oropharynx, because if you have this, then it's going to decrease your resistance to infection. So that's why we want them to have brushing and gargling afterwards. And then, of course, the other things that we need to emphasize is to make sure that they adhere to the fact that these medications do not relieve acute symptoms. So these are long-term medications which are part of maintenance for patients with asthma. Okay. So let's go to this poll. I'm sorry. I think I'm displaying the wrong slide. Um, yeah. Okay, so let's take a look at the answers over here. So the question is, the nurse is teaching the client how to use a metered dose inhaler to administer a corticosteroid drug. Which of the following client actions indicates that he is using the MDI correctly? Select all that apply. So MDI is metered dose inhaler. So what are some of the interventions or the teaching that you have to emphasize to these patients? Well, obviously that the inhaler should be held upright. Now, head is tilted down while inhaling the medication. This is not going to assist the drug going down into the lungs. So this would be a incorrect thing. And client waits 5 minutes between puffs. 5 minutes. If it's the same drug, then it has to be 3 to 5 minutes. So that's too long, right? Mouth is rinsed with water following administration. That is correct. Client lies supine for 15 minutes following the administration. Well, that's not necessary, okay? So the correct answer is option A and D. Okay. All right, that ends our discussion on steroids. And so now I'm going to go back on the slide to talk about leukotriene inhibitors. And that would be the last drug that we're going to talk about today. So I just wanted to do the steroids first because they usually are used in combination with your bronchodilators. Now, leukotriene modifiers actually is a relatively new drug. They became available in the 1990s. And these are medications that became available as a result of greater understanding of how asthma symptoms are caused by the immune system at the cellular level. So this leukotriene modifiers act on not directly on the structures, but actually on the responses to any allergen or foreign protein. So when you are exposed to a foreign protein, so like say dust, for example, the immune system responds to try to get rid of these. And one of those responses is the release of this particular substance called leukotrienes. These are a family of molecules, and they are released from mast cells, as well as from basophils and mast cells. And also eosinophils. Now, what happens whenever there is a release of leukotrienes, they cause constriction or narrowing of the airways. And in addition to that, they're going to, so narrowing of the airways. They're also going to increase mucus production in an effort to get rid of the foreign protein like the dust, and it results in swelling and inflammation of the lungs. So when you have a modifier, if you block leukotriene, therefore, what's going to happen is it's going to cause the opposite effects right here. So it will cause bronchodilation, it will decrease mucus production, which would therefore lead to lesser coughing, lesser wheezing, and lesser shortness of breath. So these are the ways in which leukotriene modifiers work. And this class of medications are easily identifiable because they have a suffix of Lucas. So Montelukast and Saperlukast are the two most common leukotriene modifiers that we have here in the United States. So again, the mode of action is it blocks leukotrienes, and when it blocks leukotrienes, it decreases inflammation and it decreases bronchoconstriction. So what are the indications? Well, it's indicated for the treatment of asthma. Actually, it could also be used for allergic rhinitis, but it's only Montelukast that's approved for that. Sometimes some people have allergic conjunctivitis. I do whenever the pollen count is very high. I usually develop allergic conjunctivitis, and Montelukast is approved to treat that as well. It's only given administered orally. It has a slow onset of action, and it's a maintenance therapy, not a drug to be used during an acute attack. So what are the important interventions as far as leukotriene receptor antagonists are concerned? Well, for Saperlukast, it needs to be administered on an empty stomach, usually 1 hour before meals or 2 hours after meals. Montelukast is much better because you could take it regardless of food intake. And the other form of leukotriene inhibitors is Xileuton. This is an extended release tablet. Usually it's taken 1 hour or 2 hours after meals. 1 hour before or 2 hours after meals. Okay? And the last one that is going to be very important in this particular group of drugs is do not breastfeed while taking this drug. So no to breastfeeding. This is usually given with, in the evening for maximum effectiveness. Okay, so what are the key warnings? Again, it's not indicated for acute asthmatic attacks, and it might cause neuropsychiatric events, and this might include depression as well as suicidal ideation, and therefore it is going to be something that you need to teach the patient to observe for, as well as the family. All right, so there are interactions, and it usually is not going to be good to give it in association with propranolol, theophylline, and warfarin because it increases its plasma activity. And of course, it's hepatotoxic as well as nephrotoxic. And therefore, we need to watch their liver enzymes as well as their BUN and creatinine. Okay. So that ends our discussion on the respiratory drugs today. Tomorrow, we'll talk about diabetic drugs or endocrine drugs. And so I hope that I have given you some vital information that will be useful for you taking the NCLEX. And once again, I want to thank you, the three of you, Jan, Francis, and Chontavia, for joining us this evening. And I hope that you come back tomorrow. Okay? Thank you, Francis. All right, we'll see you tomorrow. And I hope that you're receiving the video recordings. Goodbye to everyone. Thank you.